All right, good morning. Thank you for this introduction, Nicola. Welcome also from my side. Those who are new here today, welcome. We had a fantastic day yesterday, I think. Already a lot of interdisciplinary discussions. Today is completely under the banner of inter- and transdisciplinarity. As the 78, we're particularly looking forward to today as well. As you know, we are finishing and we will deliver, of course, a final report to the Federal Council. And at that point, we will, of course, talk about all the fantastic work that has been done. But we would also like the opportunity to reflect a little bit, right, and the learnings that we had from this pandemic for a next one. And that's what the sessions are also a bit designed for. And I encourage you to really think broadly and think freely, of course, as always, and not just of another COVID pandemic, but rather of a disease X pandemic. And I sometimes try to think, you know, what would a pandemic look like if it were caused by a fungus, for example? I mean, I watch probably too many sci-fi movies, but it helps me a little bit to get out of that box thinking and see, okay, what are the generalities we can take over from this pandemic to a next one that's not COVID? And another thing we want to really know is, for science more broadly, are things that we've learned from doing science in this extreme crisis mode, are they transferable to another non-infectious disease crisis? And if so, how, and why so, why not, and so on. So, yeah, put your thinking hats on. I mean, you always have them on, your scientists, but even more so today. Good. So with that, I would like to introduce the first keynote speaker, Lone Simonsen. Lone is a Danish epidemiologist. She's now in Denmark, but she actually spent most of her career in the US. You had stints pretty much everywhere, at the CDC, at the NIH for a long time. You spent some time at the WHO. Right. Then she had an appointment at the George Washington University, and then a co-appointment in Denmark. I imagine that was complicated. And then, but 4 years or 5 years ago, you finally moved back to Europe for good. And you're now in Denmark at the Roskilde University, where you're the director of the PandemiX Center, which is also thinking about pandemic preparedness. Right. And what makes your work so interesting, apart from having done really key seminal contributions to epidemiology, is also that Lone has always looked at the historical angle. She was the scientific face of Corona in Denmark, which gave her the nice nickname Corona Lone, yeah, which I think is very cute. So without further ado, thanks so much for coming.
Well, thank you, Marcel. That was lovely. Well, it is a great pleasure to be here and have a chance to speak about my favorite topic of all things, which is really pandemics of the past and the present, and with an eye towards the future. And because the next speaker will cover bioethics and the humanities aspects of this, I'm going to call this one Reflections of an Epidemiologist, and try to tell you some of the thinking and some of the work that we have done before this pandemic and then afterwards. After having sat through a session yesterday afternoon, I realized you're just so cool here in Switzerland. You actually have realized that pandemiology, as we could call it, if we really want to understand this concept of pandemics, we have to be extremely interdisciplinary. We have to really incorporate various research fields because all of us have a chunk of this animal. I know a lot about the tuft maybe of this animal here, and somebody else has got the tail, but all together we can stitch this together and understand how best to defend humanity against it and how to best survive it as a population afterwards. So we in our department has a lot of math and epidemiology, sort of the quantitative end, but I should tell you that 3 of my PhDs right now and postdocs are actually historians. So I'm trying to live this, that I'm not just saying it. We're really stretching to find synergy, and all of this in the interest of preparing for the future disease X, which is another severe pandemic of the future. So this is the center that I have here. I should say that it's in collaboration. All that you hear here is work of my great people at the Roskilde University, Niels Bohr Institute at the University of Copenhagen, the Danish Technical University, and the North Zealand Hospital. And we're just trying to, we set out, we got this big Center of Excellence grant to map the pandemic signatures. What can we really say about all the pandemics that went before in terms of how did they, like a fingerprint, imprint on the human population? And I just like to think of it as a new field, pandemiology, why not? So to begin with, if you really think about it from the point of view of a virus or another pathogen, the trick is really to be able to make it a sustained transmission when you cross over, and this is how pandemics are born, really, from animal reservoirs, zoonotic diseases. They cross over, the random veterinarian gets infected, and maybe he infects his wife or something, but really it stays lurking. It doesn't have yet what it takes to spread effectively in the human population, and I just drew several unsuccessful attempts there. I can't really do this. No, never mind. But one of them, the long one here, went all the way in several generations of transmission and managed to learn the trick to transfer effectively amongst people. And in this example, everyone who's infected infects about 2 people, and therefore the transmission constant, or whatever, the R0 that you're probably all familiar with after this pandemic, is 2. That means it will spread exponentially through a population if you do nothing to stop it. And 2 is not a crazy idea. In both the 1918 pandemic flu was about 2 to 3, this figure. And for COVID 2019, the original variant was about the same order of magnitude. So this is a really important thing. Of course, the other one is how long does it take to get from generation to generation? And that is, for flu, a very short interval, just a couple of days. For COVID, it was a bit longer in the beginning, but that has been shortening throughout, and that's probably why we see this mess of Omicron variants right now spreading like crazy. To just give you an idea of where all this started, the first thing I did when I was at the NIH and the CDC was to try to figure out, can we study even these pandemics from 100 years ago? And back then, around the end of the 1990s, there wasn't really that many data anywhere. But by starting working with historians, we actually managed to really do studies. Several people start doing this thing. It's like a new thing, whatever. And we in the field of epidemiology managed to really study the Spanish flu, especially, and that's really the mother of all pandemics. It came from a bird somewhere, probably in Asia, definitely a bird. We know that from genetic studies, and it spread, and probably in today's population would have caused 75 million deaths, mostly of young adults. That was the sort of horrible thing about that pandemic. Then you had the next 2 ones in 57 and 68, also with parts of their genome coming from birds, and lesser impact. These are sort of thought of as moderate pandemics, but nevertheless there they were. And that kind of was the stage as it was set for pandemic planning. As Marcel was mentioning, we sort of were very myopic in our way of thinking about this. All the world was really waiting for was a new influenza A pandemic of this kind, and all eyes were directed towards Asia and birds, and then something else happened. Suddenly we had in 2003 a major pandemic threat, coronavirus of all things, that got the name SARS. Was our first meeting with highly deadly coronaviruses, and that one was eradicated that same year by actually. It was surprising because it really transmitted quite well. It had also an R0 of 2 to 3 there in the beginning, but it was ended from some kind of combination of contact tracing and something I'll be speaking to you about a little bit later, which is the heterogeneity, that not everyone transmitted the same with this virus. Then we came in 2009, and while everybody's looking in Asia for bird flu, instead we had the swine flu epidemic starting in Mexico, and that was really, really a mild one. And I think also this is important to understand our mindset going into the coronavirus pandemic. That was our meeting with, that's our last pandemic experience globally, and it was mild. It was like nothing more in terms of deaths than a seasonal flu would be, and people just like, is that all it is? We're just like so superior now with our economy and our great health sectors. We don't have to worry too much about this. We got this. It's just more a problem for low-income countries. And then we also had a second threat with coronaviruses there in MERS, also not a pandemic, but definitely a threat. Both of these were probably the SARS, I was working on the outbreak in 2003. It's the most scary thing I've ever done in my career. And many people don't remember it maybe, but I certainly do, because 10% of the people we knew that were infected would have died from it, and for MERS it was much higher than that. So there was really a whole other ballpark of scary. Fortunately, it didn't make pandemics. And then in 2019 with COVID, we have just been through this first successful coronavirus ever. And it was less deadly, but because so many people were infected, the total death toll is huge. It's actually, in terms of, if you just count how many deaths were reported by PCR testing, 7-8 million, I don't remember what the number is right now. But more importantly, if you look at excess mortality, which is a better way to find everybody who died of this, it's probably more like 20 million people who died of this. So what can we know about, what can we learn from all of these past experiences? Is really, there's one good news piece that I often talk about when people are too depressed about all of this is, well, they always end. It takes like 2 to 5 years, a couple of waves, and then it will end with immunity. That's at least something we can know. And we also know that we're going to live with this. We're going to COVID has so much in common with the pandemics of the past that it'll end the same way. We're going to have winter seasonal epidemics, and that's going to be its endemicity, the way we're going to live with it going forward. So now we're just waiting for this future disease X, and all of you, I can see, are not terribly old. You will experience more pandemics in your lifetime, there's no doubt about it. The question is, are you going to experience more of these 100 years events that the COVID and the Spanish flu were? So I'll tell you a little bit about the 1918 mother of all pandemics that really was my first go at this. How can we study its signature? How can we understand? How can I find this virus how can I find this pandemic in lesser data? And this is the work we did in 2008 with Cécile Vibou at the NIH and 2 of my colleagues at the center here. We discovered, if you look at time series of all deaths, from 10-year period here, you will see that it was only the young adults who were at an extreme risk. And one thing we noted at the time was that there was absolutely no excess mortality, no rise in mortality at all in the people over 45. And we start worrying about what was that all about? Why was it so much the young adults? Why were the elderly spared? And again, this pandemic lasted. You can see there's actually 4 waves in this period from 1918 to 1922. And we made this hypothesis of why were the elderly spared. Maybe it was something they had experienced in their childhood that actually saved them going into their next pandemic. And so we did something fun we were able to study and find a mild summer wave in 1918 where many people were infected, especially in Nordic countries and in England and other places. It was like quite widespread, but the case fatality rate was 0.3%, not really a lot at the time. A few excess deaths, so people were writing in newspapers, physicians would write, nothing to worry about, just go about your business as always. But then in the fall wave came this dramatic mother of all pandemic event where the case fatality rate got up to 2.1%, and you had like 2 million 20 million people at the time dying, 75% in today's numbers. That was really a 6-fold worse mortality rate in the second wave than the first one. So that's interesting, isn't it? That was also something one can know from historical pandemics. It doesn't always have to be nicer over time. Sometimes it can get worse. It's not. I don't know how you're going to act on information like that. Should you go and get infected in the first wave or what? But you could think about that. The reason we could find this one, because it was a really very small and not very clear what it was that of the deaths that happened in both waves, 95% of them were under 65 years of age, 20 to 40 years of age, really. And that is significantly, that's indicative of it being the Spanish flu. So we have coined there was a first wave of this. And also its transmissibility of over 2, which we could measure from its curves, was indicative of it being a pandemic wave. So really, we have seen here a first wave being 6-fold milder. We have seen cross-protection. I don't have time to show you this, but in another study, we demonstrated that if you had gotten flu in the first wave, you were as protected in the major wave as you would if you had a modern vaccine. Later on, nobody of the virologists would believe us because we're just epidemiologists talking about statistical things. But finally, somebody found the virus in the summer, and it's a Taubenberger's group, and they actually managed to say, yes, it was true, the virus was there. And in a new European archival study, they've actually noticed that, yes, they could also find the virus in the first and the second wave and see the mutations that are probably causing this difference in the mortality in the two waves. So the other question that's really like haunting me to this day, and it will probably continue to, is why is it that people over exactly 20 years of age were at the highest risk in the 1918 mortality? And really, when you think about it, if you're 28 in 1918, you were born around 1892. That is the Russian flu pandemic. So it begs the question: had they experienced something that made them at extra high risk when in their priming years of flu, or what's really going on? And also, when you look at the elderly, the people born after 1860 or so, they really, or before 1860, they had no problem at all with this pandemic. So really, taking this all together, we have some lessons that are maybe actionable, at least it's worth to know. Pandemics will occur every 20 years. Deadly pandemics maybe every 100 years. They come in waves. You can't just expect one major wave. For whatever reason, they tend to come in 2 to 4 waves. There's something about the first flu you experience, and there could be protection from previous pandemics. And really the way we saw this loud and clear was in the 2009 pandemic, where people could, again, it happened that only people over under 60 years of age were likely to die from that. The elderly were spared. But that time, you could actually look at data from blood that was harvested, that was taken in 2008 before the pandemic. And you could see they already had the protective antibodies in their blood, the people who are 60 years and older. So now it's no longer a hypothesis. We know there's something about something you can carry over time that matters in the future. First waves can be maybe milder, they can also be more severe, but in 2 of the pandemics we've studied, it was actually milder at first than later. And then eventually you will come to herd immunity, a lot of immunity in the population, and they will go over to be seasonal epidemics. That's, if you ask most experts, they will say that's how it will end. We'll have winter epidemics of COVID. And I think really my best evidence of this is really comes from another coronavirus in the same family, beta coronavirus family, which is called OC43 and causes your children and grandchildren to get the cold in the winter. They're winter epidemics. They must have been a pandemic some time earlier. And therefore, we sort of have already observed the endgame of a coronavirus. Now we have COVID-19 declared a pandemic, March 11, 2020. Our world's changed. And I just wanted to give you an idea about how we were thinking about control, because it was really very murky thinking when you look at it. First, we had the WHO advice to test and test and test, and I think really what they had in their mind was SARS from 2003. If you find all the cases and you track them down and you isolate them, you can stop this again. And it really was probably not advisable, because it already had some characteristics that would not make this possible. I'll show in a bit. The other idea was comes actually from 1918 pandemic, that you can, instead of having a mean red nasty wave of mortality, you can and morbidity, you can spread it out by doing something, by mitigating it in various ways, and you can get this pretty green wave instead. And that was sort of the thinking, at least in Denmark. I think many places, let's keep this low to make it so that the health system can survive this threat, so that not all our hospital beds will be full of people. But what SARS was different, as it turns out, from SARS-CoV-2 in 2019 was so different from SARS in 2003 for 2 major reasons, and that really explains why 2003 virus could be eradicated that same year, while this one went on to cause a major pandemic. And the trick one is really that infectiousness begins 2 days before symptom onset. If I can infect somebody else without even knowing I have the disease. And trick 2 is really that many never develop any symptoms, yet they can transmit it to other people. So this is information we had very early on, and it made me think that really what we have is a virus that can go under the radar, very different from SARS in 2003, much more like the pandemic flus that we have so much experience about. So then we set out for the green wave thing in Denmark here, probably in many other countries. And what happened, to our big surprise, was we locked down in March 13, 2020. And instead of getting this green wave, instead we got this little yellow sort of flop thing. It just really controlled whatever we were doing, totally controlled this pandemic, and it knocked it down. We thought maybe it was the weather, maybe it was something we couldn't quite explain this, but it was of course a good thing. And after that, we dropped the red-green curve thinking, and instead thought of it as a let's keep this R0, let's press it down to a contact number below epidemic control, so below 1. And that's really what I could call, we never really talked much about what this would, I would call it many small streams make a big river approach. You do a lot of things, and all of them will contribute to epidemic control. So in Denmark, we did all these things on the list here, and probably most countries did. But we had an unusual hard focus on mass testing. And it really comes from this idea, why couldn't you go in and find cases really fast with antibody testing, and then pull them out of the infectious pool, and that way get a lot more control over the epidemic. And actually it turned out it was quite effective. We believe that if you had just tested those people who were symptomatic, which most countries did, you would have found the blue cases over time. But if you did the PCR testing, you would have found the orange cases, and with the antigen testing, we found the red cases. So really most of the cases that were identified at any time could be told, go home, stay out of circulation, and isolate yourself, and that way we got a better epidemic control. And from doing some math on this, we figured probably we could reduce transmission by 25% by this one thing. And of course, this was extremely expensive if you think about it. Every Dane was tested every 10 days. And we had the Corona Pass requiring testing every 3 days if you want to go around, and all of this before we had the vaccine. So really it's something to think about for the next pandemic. Was this worth it? Was this something that, and I can only say it worked. From the health perspective, it worked. Was it worth it economically? That's another question. I don't think we are done with that one yet. Another obvious question when you stand in front of a new pandemic threat is, of course, how deadly is it? It could be anywhere from mild, like 2009 pandemic, to really severe, like the 1918, or even worse, like the pandemics of the Middle Ages. So you could ask, what's the risk of dying? What's the excess mortality? What's the worst case scenario if I do nothing? And what's with this chronic long COVID anyway? And the reason, I just wanted to tell you, this is really a hard question. It sounds easy, but it's really difficult, and it happened in the 2009 pandemic. The first assessments that appeared in Science figured this pandemic was really severe, maybe somewhere in between 1957 and 1918, like really in the red part of the spectrum. And it turns out they were about 100-fold wrong. So it really was quite a mild. But that's just hard to do because in the beginning you only see the severely ill people. You don't see all the people who have the infection. That takes some blood donor or serology studies to figure out who had the infection. One other thing is that we very clearly found out that the dominant mortality risk factor is old age. There's no doubt about this. You see this in many studies from China in the beginning and Italy, and wherever this epidemic got a foothold, COVID, you would see this thing that being in old age is really bad for you. In Danish nursing homes, for example, we saw that elderly who were very frail, 90 years of age, could have a mortality risk as high as 30% if they were infected with this virus before the vaccines. And then you can, of course, say, well, it's just because old people have a lot of comorbidities. But in this British study, they sort of sorted them out. It's sort of controlling for all kinds of factors. I'm sorry, it's written in Danish here. But the gender, the BMI, the ethnicity, whether they had diabetes, all these things are now controlled for. And even so, being over 80 years of age is banging out in its own league. It's simply age is the most important risk factor in this pandemic. And that's very different from the past pandemics that we had observed with flu. It's something we have to understand is probably this pandemic was especially a threat for wealthy countries with an aging population. Another thing we saw that we hadn't really seen coming was the evolution of the SARS coronavirus over time. We started with the original variant, then we got Alpha, then we got Delta, and now we have Omicron, this and that, and it just goes on. And it's over time, the R0 of this virus increased. The Delta was horrifying. It had a really high R0 of 6 to 8, plus it was at twice the mortality risk as the original virus. That's not a good time. So that's another example of things getting worse over time. But now with the era of Omicron, where most people are vaccinated or already immune, things are looking much different. But if you look at why should we worry about these R0s, it's really because it determines how many people have to be infected before the infection will be done, or the epidemic will be done. If you have an R0 of 2.5, maybe you need to get 60% infected before you have immunity. If you have an R0 like Delta of 6 to 8, you have to get all the way up to over 80% immunity before it will stop. And that's not the only factor to worry about. Also, you have to worry about the serial interval and the degree of immune escape, which Omicron was the first global variant to also be able to escape immunity. And therefore, that's one of our PhD students is just trying to understand all these phenomena that's going there. But that was really a thing that made me think, now I think I understand why there was waves in past pandemics. It probably was really variants that were coming through and doing their thing. I hadn't thought of it that way before. Now I have to go back and rethink when I look at the zero epidemiology studies from back then. The Omicron is really the time when the Danes just let it go. We had excellent epidemic control in the two first waves up to the time where everybody was vaccinated, and only 10% of Danes had ever had this infection before they were vaccinated, and then we just let all stops out. We just opened the society as one of the first countries in the world, I think, and we just said, okay, there's nothing more we can do, right? We're all vaccinated. Here's Omicron, is no worse than the first one, and that's when all the Danes got it, and from serology studies, 70% or something like that had it in that way for the first time. And then you see that there was also some hospitalizations and deaths there. And of course there's more because there was many more people getting infected. And that has been really hard to communicate because people just like, wow, we just do all this and we do all the right things and then we have more deaths. How do you explain yourself? Stuff like that is what you do on TV, try to make this understand that it was actually not so surprising that happened. The vaccines were highly effective against severe COVID, and it remains that way. And that's also something that has really been misunderstood. In Denmark, we had an extremely high trust rate, so that 95 of people over 50 years of age actually got vaccinated with boosting and everything. So we really well protected. And if you look at the effect of the vaccination over time in different age groups, it was super high, much better than we could have hoped for. This is really the miracle of vaccination we are witnessing here, and we just did it on the surveillance data we had because we're testing so much in Denmark, and we could really and we know by CPR numbers who's gotten vaccine. We could just do this very easily in real time. So what's new about this pandemic is we can use a vaccine, it can be effective, and we can study its effect in near real time. That has never happened before, not even in the 2009 pandemic. Excess mortality is something that I've spent a lot of my career working on because it's such an excellent way to look and compare severity over time. Here you see the Euromomo surveillance system, which Switzerland is also a member of, and you can see really across Europe what does it look like when you have seasonal flu and what does it look like when you have COVID there. It's some kind of combination of the infection fatality rate and then how many people have been infected. What's the chance of dying when you get the infection times how many people were infected. And that, if you do that kind of modeling for all kinds of countries, you will see that countries fared very, very different. You have at the bottom here the cumulative excess mortality. Countries in Scandinavia and New Zealand, Australia, really low. And all in the top, you have countries in the Eastern Europe. And here's Bulgaria just really banging out with 1% of their population having died of coronavirus. And it's partly certainly due to them not wanting to have the vaccine. There was a lot of vaccine mistrust in Bulgaria, and only 30% of people were vaccinated, including the physicians didn't want to take it. And so this is kind of what happened. It got really bad. You see Switzerland somewhere there doing pretty well, but not. You definitely had more people infected and lower vaccination rates than we did in Scandinavia, and that shows up here in the total death toll that way. Now I want to get back to this surprise, this little yellow thing. How can we understand that we just got a little yellow curve instead of this green wave in the beginning? And to understand this, you have to think about COVID super spreading, which you all remember right from the start. You had these outbreaks reported. Here's one from Switzerland. There was an infected bartender with a flute, and there was a lot of people in the room. And what happened? It was a super spreader event due to a combination of presence of someone who was infected, the behavior that spread it out in the room, and then a large crowd ready to receive it. And actually, interestingly, Austria was not on the list of countries that we tested for in the beginning of the pandemic, and most of the cases in Northern Europe is seeded from exactly that country. So this was not trivial. This actually can reflect later on. But this was very much called attention to by the Icelandics, who were very good in the start at sequencing the pandemic because of their decode center. So they called attention and said to the WHO, you should really look at Austria. But it took a while to get it to happen and to react to it. But we thought, what can this really mean when you have super spreading? Could it be that it explains our ability to control COVID? So in the left picture, you have corona-like spread. The R0 is 2, the average is 2. That's true for transmission, but it's only some people who give most of the cases. Maybe 80% of the cases are caused by a few people. In the other one, it's just very much more democratic. What could that mean in terms of control? Yeah. So for corona, 10% of infected infect 80%. So we used an agent-based model to really understand what this was. And the idea of looking into this was not new. It was thought about by Mark Lipsitch and his team in 2003 during SARS. We really should try to understand this better. What's with the super spreading? It should come into our models, but nothing happened. We have James Lloyd here looking at the phenomenon of super spreading and talking about a dispersion parameter. You can really call it something that very super spreading organisms have a very low dispersion parameter. It's how much difference there are between people's chance of transmitting. So in one end you have SARS, and the other end you have flu. There's something here we need to understand better. So we did this modeling and found out that if you put in a super spreading in agent-based model, if you did not add super spreading, you could regulate contacts in the random space and not achieve very much. But if you put super spreading in the model, you actually get this little yellow curve thing. You can really mitigate this completely just because when you actually go and reduce the contacts you have in the public space, in the metros and the concerts and everything, you make this virus lose its cool, because that's where it makes most of its transmission events. So that was really something we actually have then published and thought about really as the Achilles heel of the SARS coronavirus 2. Thank God we had the over-dispersion, the super spreading, because it made it possible for us to control the virus until the vaccine became available. And also you had to think about, well, what does this mean in terms of airborneness? This, obviously, if you can super spread in the whole room, it has to be in small air bubbles that float for a long time. That thinking needs to be developed. You could ask from a public health perspective, why did it take full 2 or 3 years for agencies like WHO and CDC to start talking about this being airborne? That really was too long, because we knew it already from the super spreading being so important. And that's just something we are just sorting that out in Denmark right now. How should we talk about that, and how should we go about improving air quality in the future for COVID, but also for other for other epidemic diseases? So what will happen next? Well, globally, it looks like we're at the end of this pandemic. Everything is slowing down. We had a little uptick there when China opened up their zero COVID politics. But globally, overall, this is coming down. This is the mortality shown in 6 different regions of the world. It's definitely going down. And I think we're definitely at the tail end of this thing. So the COVID endgame, we have to think about it like, well, we were lucky in some of the countries, like in Scandinavia, certainly, also to some extent in a country like Switzerland. Most people got the vaccine first. And this virus will find everybody, so it's better to be meeting it with some vaccine protection, because it will decouple the epidemic. It will make it so that yes, you can get infected, you may even get sick, you may even something, but you will not get hospitalized and die in the same way as you saw in my figure before. Your risk of that kind of thing drops to 10%. Or less. Then you also saw that most of us have managed to first get the vaccine and then get subsequently infected during the Omicron waves, when you have the milder version of the virus that's more upper respiratory, which really was a good thing. I think this will end because of the combination of vaccines and natural infection. You get this that's called hybrid super-duper immunity kind of thing. You actually not only have antibodies that work, you also have your T cells, all immune epitopes that work, because now the immune system has seen the whole virus, not the spike protein of the vaccines. So I think this is what's going to take us to the end. The population will simply be so immune, it can handle this. It'll go into endemicity, be winter seasonal. And when will that happen? People always ask me this, so I update my slide and put a year later on it. So now it's, 20, I don't know, but very soon this will not be something that happens in summer anymore. It'll be a winter virus, just like OC43 or seasonal flu. And then we have to worry about what should we do then, how should we control it? I think it's going to be like with autumn boosters, just like we have for seasonal flu. And then the thing to worry about really is the long COVID. And I didn't have much time to develop this here, but actually the one a really characteristic of this pandemic is that some people get serious sequelae that last for a long time and can be debilitating. And how will that be in the future when we go into 10 years from now? Will there be a big log of people who are actually still struggling with this? That's a question for the Swiss Research Council to keep on top of long COVID. This is an important thing. Now, I don't have much time to talk about this, but it's not like disease X is not lurking already. We have this influenza H5N1 now in a new variant, spreading, killing birds everywhere, infecting mink for the first time, spreading effectively in mink in a mink farm in Spain, scaring me quite a bit, just here in recently. It's like you could think of animals like minks as a training camp for this virus. Mink live outdoors, birds fly by, infect the mink, and they are like the virus is in a training camp to become better at spreading and become a mammal and human pathogen. So this is something, mink farms is a very political issue in many countries, especially mine. But this is an example of how politics can meet pandemic concerns. And I should say that if H5N1 was the next disease X, I'd be worried also because in this study of H5N1 cases globally up till now, published in Science in 2016, it turns out if you get the H5 variant, you are likely to be born after the 1968 pandemic. Making people in this paper and the commentary, which is wonderful if you want to read The First Flu Forever, is really about that something, if you're primed in your childhood by a virus, and these, whatever you were primed with before the 1968 pandemic would have protected you against H5, but all the young people don't have that. So totally unlike COVID, an H5N1 pandemic, I'm guessing, would be more a challenge for young people. So how do we remember this COVID-19 pandemic? And really, I think most than anything, we'll have to reckon with the fact we were ill-prepared. There was a shortage in tests. We couldn't test. We didn't have the ability. There's a shortage in protective gear. You have nurses struggling still with long COVID because they couldn't protect themselves in the early phase. We had draconic lockdowns. We thought we were done with this in the Middle Ages or something. But no, we had this disaster in northern Italy in March 2020, which really showed us that even a modern-day country can get to its knees from a virus like this. And we were super lucky. Our strategy was really to wait for the vaccine to come, and it came after 8 months. That was really, really lucky. We were not good at sharing this one resource. If you look at low and middle income countries, their high-risk populations were only vaccinated or offered the vaccine way after our low-income population had been offered it. So that's really an ugly spot, and that maybe you will be speaking about, I don't know. But if you look at this globally, this was not pretty. We remember there's a high excess mortality, lowered life expectancy. In countries like Bulgaria, the life expectancy is down many years now. And then long COVID is how we will know it going forward, because all of this will be forgotten soon. But the people living with long COVID, that's going to happen into the future, and that's something we just have to reckon with. And then I'm hoping that for all we've been through and for the historical knowledge that we have, we can prepare ourselves better for disease X. And it certainly will involve an interdisciplinary approach. Otherwise, we will not understand why some people don't want the vaccine when really it's there and it's the only thing that will keep you from miserable meeting with the next virus. So thank you, and that was it for me.
Thank you very much. We have mics going around, so if there are any questions, we're happy to take them. Just maybe want to get started.
Yeah.
So two things that obviously stand out next to each other is that, okay, the first lesson is that they're all airborne, the pandemics.
The COVID.
Yeah, but all the pandemics, right, you said are respiratory diseases, right,
Those
historically.
The influenza pandemic, I wasn't clear about this. All the influenza pandemics and influenza seasonal flu is like a short distance spread, fomite spread.
Yeah.
That's different with the COVID and the SARS and the MERS. These are airborne.
Okay. Yeah. There's some emerging data also that influenza is airborne.
I saw that, yeah.
At the same time, right, you said we're not serious about airborne transmission. I mean, here it's not much talked about anymore. As you said, the WHO, many public health agencies have taken a long time.
Yeah.
And these things together obviously are somewhat worrying, right? Yes. So what's your view on that? I mean, what's going on there?
First of all, we need to just get with the program and figure out what we think about it. If you go in on the CDC's website, you'll see that influenza is a fomite-borne disease, certainly not airborne. But yet there are papers like the one you mentioned out there. I think from the fact that you rarely see influenza super spreading, you can sort of reckon that it's not an airborne disease. But we need to understand all this much better. And of course, we need to understand once we start keeping the air quality clean and really maybe keeping our children away from diseases for a very long time, because we just like sterilize the environment really. Can we do that? And what would happen then? Because sooner or later you're going to reckon with all the childhood diseases anyway. So that's something that keeps me awake at night. What would that look like once will we just change the epidemiology of all the diseases? What will happen?
Yeah. All right. Do we have questions?
I have a question. Yeah.
Yep.
Hi, Tom Peter, ETH Zurich. Thanks a lot. Great talk. Question by a physicist, so I don't know much about your field. You said a pandemic eventually becomes a seasonal epidemic or something like that. Yeah. And then there's the wild cat and the mild cat comparison. Now, influenza is also not a harmless small cat, right?
Right. That's why I made it a mean-looking little cat, not just a little sweet thing.
Okay. My question is, that sounds additive. So nature invents those viruses, they all go that way, and they add up on our burden. But there must also be viruses which completely phase out. And what do we know about that? And wouldn't it be valuable to know something about that, to understand how they eventually completely go away?
Well, if you look at over time, we look at 3, 4, 5 centuries over time, you will see that some pandemic threats definitely phased out because of our transitioning into modern societies. So all that we've done in terms of hygiene and all of this has excluded us from a risk of a cholera pandemic or something like that. So that, as I mean, a lot of things have helped the safety of our food supplies, and so you don't get the foodborne diseases like we had in the past, really bad epidemics. So some things have disappeared, but if you look at the epidemic diseases like measles or anything, it's all thought of as childhood diseases now, but they must have been pandemics at one point, and they're still with us. I don't think they just disappear like that. The ones that are ill-adapted, like the SARS in 2003 and MERS in 2012, and even monkeypox maybe in 2022, these will not, they don't have it yet, the full force that it will take to be maintained as endemic diseases, but the other ones will survive it. And be with us. I don't think they disappear like that. The only way they can sort of disappear is by making childhood vaccine programs. Like measles is a lifelong protection against measles that you get in childhood from the vaccine, and then you don't see it again. That's just, you're done with it. But in many cases, we don't have those excellent vaccines options. For various reasons, you have to keep vaccinating or facing the disease again in old age, like shingles, for example.
Thank you.
Hi, I'm here.
No, okay.
Urs Graber, University of Zurich.
Hi.
Can you perhaps comment a little bit about your notion that the minks are important for influenza virus mingling and reassortment? I thought traditionally it is the interplay between the pigs, the chicken and humans that make the reassortment very effective for new types of variants and genetic hybrids of influenza virus. So why the mink now?
Well, thanks for saying this. I didn't really have time to go into it, but our sort of mental image of how our new pandemic viruses created is what you're saying. It's the pig living with birds on the roof and meeting human and bird viruses can meet in the pig, and they can handle both, and they can mix and merge and appear as a pandemic virus. This is how we thought about the origins of human influenza pandemics. But now I'm thinking for corona, it might just be clearly mink could play a role. Also for these bird flus, simply because pigs are nowadays kept indoors under very sterile conditions, but the mink farms, they live outdoors together with the birds, and this actually is a model. They have an immune system that is very resembling ours. They are often a go-to animal when we do experiments in influenza. So why not think of them as a new mixing vessel for very much the same reasons?
Mm-hmm. Okay, so it's not yet super threatening.
It has happened once in Spain. I'm just waiting for it to happen 1,000 times on never again. Then we'll know if it's important. But I think that people in Europe in the controlling the COVID situation in minks, they should really immediately start testing for H5N1 also and be on top of this possibility, because the virus is all over the place and causing a bird pandemic right now.
We can take one more question here.
Marcel Weber, University of Geneva.
Yeah.
My question is about super spreading. I found this result that super spreading makes control via restricting mobility more effective.
Yeah.
Is it also true that super spreading also makes the spread of the pandemic more difficult to predict, because individual chance events can percolate up to a huge effect, whereas when you don't have super spreading, like in the case of influenza, that this makes predicting the pandemic easier, because it's as it were more even in terms of so chance events happen, of course, but they don't have they don't percolate up like this without super spreading.
Yeah, I think that's a good point. If you have an early super spreading event in a region in a country, you could just end up be like Lombardy, the northern Italy part, that just faced this first in Europe. just because of a soccer match in Milan, and suddenly they had super spreading events in that context, and suddenly 50% of everybody in Bergamo city were infected with this virus before we even thought it would come to our countries. And so it can be very spotty. And when you see these historical pandemic flu, they're sort of sweeping slowly and surely across the globe. Even before airplanes, they managed very well. But it's very sort of like a sliding thing. So maybe it is more like stochastic this year. That's a good point.
Thank you.
All right. Thank you very much again. So here's a local handmade sweets, very contagious, but in a good way.
Thank you very much.
And please, thank you again, Lone.